A very warm welcome to the 9th of the INI recall sessions that we are actually doing. We started off with 2020 November, that is when the first of the INI exams happened. We did start recall sessions from 2020 May, but 2020 November is when we had the original first INI exam. And so we are now into the 9th exam, and the 9th exam was conducted in November 2024. So November exams traditionally have been much more easier, they've been much more predictable, and they've almost always mirrored the May exams. Rather than throwing in huge surprises, they've almost always been along the lines of what the student really wants. But at the end, does it really make a difference? No, competition gets more stiffer, but at a personal level, you feel much more happier after giving the exam and coming out, because the exam has been very predictable. It's much easier, and you feel like you can do this, you can answer. But finally, those 5 or 10 questions might make a big difference. So starting off with this beautiful city, Luxembourg is one beautiful place. Luxembourg city is what I have actually shown you. Luxembourg is a small landlocked country in Central Europe. It's like one of the 4 institutional centers of Europe. Like you have Frankfurt and Strasbourg and Brussels. This is like one of the 4 institutional centers. You have the court of the Central Court of Europe actually located in Luxembourg, and famous for a lot of reasons. Most importantly, the fact that it's a very wealthy country. I think the most richest country in the world is Luxembourg. Now, why you're bringing Luxembourg into picture is because of the terrain of Luxembourg. Now, Luxembourg has got a very, very unique terrain, wherein the northern part of Luxembourg is very, very hilly and uneven, and the southern part of Luxembourg is very smooth, and you're having one of the most smoothest terrains in the southern part of Luxembourg. This is quite similar to what the INI exam has to offer. We have a May exam which tends to be kind of up and down, up and down. That's the northern part of Luxembourg. And then we tend to have a southern part of Luxembourg resembling November exam, which tends to be very much predictable. So hopefully some of you are fortunate enough, some of you have already gone there, but like others, hopefully are fortunate enough to visit the city. It's one beautiful place. And you can see over here, you have Belgium here, you have France here, you have Germany here. So it does make it even beautiful. So that's about Luxembourg. Let's get into the matter straight. So as we've been always kind of talking with respect to the INI exam, INI exams tend to have a kind of a free kick pattern. Is it easier to score a goal, on-field goal, or is it easy to score a free kick goal? Means you can practice and score a free kick goal, but like you can't do that. On-field goal has to organically happen. So INI is more like a free kick or a penalty corner, as I have tried to always kind of make a comparison in hockey with a penalty corner or a free kick in football. So means okay, these are the zones. Let's try to study the zones and then try to hit it hard. If it is aim setting the paper, then very likely that you're going to succeed. And majority of times it is aims. So as we have discussed this many a times, the king subject always is endocrinology. You always get a handful of questions from endocrinology. Hematology is number 2. Hematology also you do get a handful of questions. Nephrology is number 3. Here again you get a handful of questions. So these are the 3 prime specialties as far as INI is concerned. Alongside with this, 100% you get questions on ECG, ABG, so we can actually include ABG under nephro. So these are the things, and the representation of the rest of the subjects are actually speaking very, very less. In fact, you look at pulmo, you know that most of the time you get one question on pneumonia, that's it, nothing more, nothing less. Liver and gastro, either you get a question on hepatitis B or nothing in liver, that's how it is. Gastro is more or less a question which is centered around celiac disease and one question on ulcerative colitis, that's it. This time we get 2 questions on ulcerative colitis. So that's about pulmo, that's about liver, gastro. Then you have neurology. Neurology is almost like a neglected specialty as far as INI is concerned. You study so much in neuro, finally to ask you whether spasticity is human or element. So these kind of questions only do come. So neurology is like kind of a neglected specialty. You get 1 or 2 questions, that's it. Then core cardiology. Core cardiology, apart from the ECG, you hardly get any questions in core cardiology. Like we discussed last time, maybe 1-2 questions on constrictive pericarditis or your cardiac tamponade constrictive pericarditis comparison questions, or 1-2 questions on valvular heart disease, but even this time that's missing. So essentially you can kind of get away even without studying all these things properly. And infection part, generally even if you know the microbiology of it, I think you're safe most of the time. So this is essentially the core. It is from here that you get vast majority of questions, and we know in ECG and ABG the number of questions can differ. Sometimes you may get 3 or 4 ECGs, this time you got only 1 ECG. You may get 2 or 3 ABGs, this time we got only a straightforward question, no need to even find out the diagnosis. So this is how the exam spans out. So you essentially know that, okay, this is the way that I need to approach this on the whole. So always endocrinology is top, hematology and hematopathology very important, and nephrology also. But nephrology also just keeps varying. But the center of the fulcrum is always rheumat. Rheumatology is a subject or a science which is gaining in importance year by year, year after year, year after year. So what happens is, as the exam tends to progress towards clinical, the number of questions in rheumatology is always going to be on the rise. And if the exam is like more theoretical, then you may not get so many questions in rheumatology. That's how rheumatology is. So that's why I always say these three have to be there. And you have to watch all the videos on rheumatology, not because thinking that you're going to get a question on polymyositis. No, because the video on polymyositis may help you in a different chapter, in a different question, because rheumatology is right at the center, and it is exam is about integration. So rheumatology, of course, will hold the center stage. So keeping that in mind, let us quickly go to the questions. The aim of this is again just two things. One is for the student who knows that okay, INI will happen next May, unlike your NEET, which we really don't know when it's going to happen. So you can set a target for that, you can make a plan, and you can approach. So there's a definite approach, hoping that AIIMS is going to set the paper. If AIIMS backs out and then PGI or JIPMEN comes up with the paper, then it can be a bouncer, but then it's a bouncer for everyone. But if AIIMS is setting the paper, you know, okay, at least these are the core zones and I have a chance because I know what I'm preparing for. I know how many months I have at hand. So all these things make our preparation far more easier. And of course, studying in a central institute is no way comparable to anything else. And that's something which even I have not been able to achieve throughout the course of my MBBS, PG and DM. I have not studied in the central institute. So central institute is always special. And when you pass out and when you come out into the market with respect to jobs and job opportunities, people who have done their course in central institutes do have a bit of an edge, a small edge. Okay. So let's go to the first question. So what are the causes of high anion gap metabolic acidosis? So this has been something which I think this is another thing I want to stress on. Even if you don't prepare and you are an intern who is actively in the hospital, and once in a while when you get time, do a few questions as well as do a few videos, you are well and truly in with a chance, because majority of these questions don't require you to have any in-depth knowledge that you have to sit and study. If you know the basis, then you are fine. So this is about it. Now, all of you know that diarrhea is a cause of normal anion gap metabolic acidosis, and Ka, Ki and inborn errors of metabolism are all cause of high anion gap metabolic acidosis. So I just really don't want to confuse the picture anymore by teaching you everything about anion gap and stuff. But let me just tell you this simple logic which will help you many a times, that the total cations in the body is equal to total anions in the body. So total cations means measured cations plus unmeasured cations will be equal to measured anions plus unmeasured anions. Measured cation minus measured anion will be equal to unmeasured anion minus unmeasured cation, which means measured cation is sodium, measured anions are chloride and bicarbonate. So sodium minus chloride plus bicarbonate will be equal to unmeasured anions minus unmeasured cations. What is sodium minus chloride plus bicarbonate? That is called anion gap. So anion gap is equal to unmeasured anion minus unmeasured cation. Correct. Which means that whenever you are having loss of bicarbonate, that is actually called as acidosis. Correct. Whenever you are having loss of bicarbonate, that is called acidosis. When this loss in bicarbonate is compensated by an increase in chloride. So when the loss in bicarbonate is compensated by an increase in chloride, then that loss in bicarbonate is being compensated by an increase in chloride. You get what? You get hyperchloremia. Okay. You get hyperchloremia plus you are getting acidosis. So this is called hyperchloremic acidosis, because the loss in bicarbonate is compensated by an increase in chloride. When the loss in bicarbonate is compensated by an increase in chloride, can the anion gap change? No, because anion gap is sodium minus chloride plus bicarbonate, which makes it a normal anion gap hyperchloremic acidosis. So that's why whenever you are having a loss in bicarbonate being compensated by an increase in chloride, you get what is called normal anion gap hyperchloremic metabolic acidosis. So this is called as normal anion gap hyperchloremic metabolic acidosis. And whenever you are having an unmeasured anion increasing, okay, whenever you are having an unmeasured anion increasing, that is called as high anion gap metabolic acidosis. So we are having high anion gap metabolic acidosis and normal anion gap metabolic acidosis depending upon what is the actual problem. When bicarbonate is being lost and that is being compensated by an increase in chloride, you get normal anion gap metabolic acidosis, which is called as hyperchloremic. And when you are having an increase in unmeasured anion, that is called as high anion gap metabolic acidosis. Very clear. So to get a high anion gap metabolic acidosis, this is raised anion gap metabolic acidosis, what we call HAGMA, high anion gap metabolic acidosis, everything is the same. You need to have you know that anion gap is equal to unmeasured anions minus unmeasured cation. So who has to increase? Unmeasured anion has to increase. So what is unmeasured anion increasing is what we are seeing. So this unmeasured anion can be very much a keto acid, correct? Yes, unmeasured anion can be a keto acid. That is why wherever you are having keto acids, you get high anion gap metabolic acidosis. Say for example, diabetic ketoacidosis, alcoholic ketoacidosis, starvation ketoacidosis, and you can even get something like a euglycemic ketosis. Euglycemic ketosis is what we see typically with your SGLT2 inhibitors. So diabetic ketoacidosis, alcoholic ketoacidosis, starvation ketoacidosis, euglycemic ketoacidosis, all these things are part of the keto acid. So keto acid is the first thing that can actually increase. Second thing that can actually increase is lactic acid. So anything that has got to do with lactic acid is very, very, very important. Any kind of metabolism which leads to increase in lactic acidosis is going to basically manifest as high anion gap. And that is the reason why even when you are talking about a ventilation perfusion mismatch, even when you're talking about sepsis, even when you're talking about hypoxia, then you are actually getting lactic acidosis. Or in simple terms, I would say that type A lactic acidosis, which is due to hypoxia. That is one thing, and everything you can actually kind of bring down to hypoxia. We also have a type B lactic acidosis. Type B lactic acidosis does occur in liver failure. You have a lot of drugs which can cause that, and we have inborn errors of metabolism. So inborn errors of metabolism, drugs and liver failure are all cause for type B lactic acidosis. And what are the drugs? Whole lot of drugs, but again, almost all these drugs have come for the exam at so many different times. But I think ethylene glycol, yes, especially glue industry and all that. Then methanol, then salicylate, then paraldehyde, all these things. Fenformin was there. Metformin we don't generally associate so much. So ethylene glycol, methanol, salicylate, paraldehyde, all these things. Third one is uremic acid. Yes, so uremic acid. So the unmeasured anions can be lactic acid, uremic acid, or a keto acid. And uremic acid you get when you're having CKD or even with the AKI, when you're having a decrease in GFR, you expect the unmeasured anion, which is the uremic acid, to go up. So when you think of something like a high anion gap metabolic acidosis, the easiest way to think about high anion gap metabolic acidosis is that unmeasured anion increases. Unmeasured anion can be a keto acid, it can be lactic acid, or it can be uremic acid. If you think this way, then it becomes very easy. I have taught you so many other methods also, but like practically this looks like a very simple method. Then comes normal anion gap metabolic acidosis. Whenever you think of normal anion gap metabolic acidosis, it is RTA, 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 renal tubular acidosis type 1 or renal tubular acidosis type 2 or renal tubular acidosis type 4. All these things are associated with NACMA. NACMA for you practically is this. Or it can be a case of WDHA syndrome. What is this WDHA syndrome? Watery diarrhea, hypokalemia, acidosis, which is typically seen with a VIPoma. So diarrhea, which is typically seen with a VIP secreting tumor, watery diarrhea, hypokalemia, metabolic acidosis, which is also called as the pancreatic cholera. Yes, pancreatic cholera. So watery diarrhea, hypokalemia, acidosis, which is basically normal anion gap metabolic acidosis. So this is the second cause. And you can even have a leak, which is part of a pancreatic leak, which can be a fistula, which can be a part of ureterosigmoidostomy. All these things are there. So ureterosigmoidostomy can be there, fistulas can be there, small bowel or pancreatic fistulas, or leak can be a part of this. So essentially these are the causes, and you know that RTA has a positive urine anion gap. That is how you actually differentiate RTA. So RTA has a positive urine anion gap. Okay, I'm not going into that detail now. So essentially, when you think of a high anion gap or a normal anion gap question, at a basic level, this is all that you need to know. Advances with respect to this, the tricky part with respect to this for a higher order thing, I'm not discussing here. You can actually see that in the video because that is to that level has not been asked. But simple terms, if you keep in mind that the unmeasured anion increases, and what are the causes for an unmeasured anion? It can be lactic acid, it can be uremic acid, it can be keto acid. That way you can actually get all that. Or you can think that, okay, it's a hyperchloremic normal anion gap metabolic acidosis, which has broadly three causes. One is RT, and then the three types of RT, that's RT 1, 2, 4. Then you have this GI loss. GI loss is typically equal to watery diarrhea, hypokalemia, acidosis, which is what we call as your pancreatic cholera or a VIPoma. And then, of course, you are having this ureterosigmoidostomy or a biliary secretions or a small bowel fistula, all those kind of things. If you have this much in mind, it's fine. There are integrity issues with respect to this. That means when you treat a patient with DK with normal saline, then what happens is that he will start getting hyperchloremic acidosis, which means that the anion gap will come down and he'll come into normal anion gap. Same way, you are having a patient with CKD. In the beginning, he has normal anion gap. Later, it becomes high anion gap. So those are the higher end points. But basically, they're not testing out for any of those things here. Simple basic question. Don't get confused. Inborn arrest of metabolism we have seen is high anion gap. AKI or renal failure is high anion gap. DK classically is high anion gap. Okay, so that's the first question. Even if you don't know any of these things and you have a code like Kusmal and you know that we can answer this question, but in case tomorrow they flex or extend the question 10%, 20%, you should still be okay with that. As per KDGO, which of the following falls under 3B? We always keep talking about CKD with respect to G and A, and what have I taught you? Somebody who has G1, G2, G3, G4, G5. What is G5? Less than 15 ml per minute. And what is less than 15 ml per minute equal to? The uremic phase, or what we actually call as end stage renal disease, and this is where most of the patients will require dialysis. What is G4? G4 is 15 to 29 ml per minute, 15 to 29 ml per minute. Then G3 is 30 to 59 ml per minute, so 30 to 59 ml per minute. What is G2? 60 to 89 ml per minute, 60 to 89 ml per minute. What is G1? More than or equal to 90 ml per minute, more than or equal to 90 ml per minute, but we're having a radiological or biochemical or histological evidence of kidney disease. So radiological, biochemical or histological evidence of kidney disease. This is called as your G1, 2, 3, 4, 5. And in 3A, what have we specifically discussed? We've discussed that there is a 3A as well as 3B. So when you're having 45 to 59, you call it as 3B, 3A. And when you're having 30 to 44, you actually call it as 3B. So when you go from 1, 2, 3A, 3B, 4, 5. So that's how the order is. But when we teach from 5 to 1. But when you say more than 90, 60 to 89, you can actually go with that order, which is a 3A and 3B. So the question is on what is 3B. So 30 to 44 is actually what we call as 3B. Same way, we also look into A, that is A1, A2 and A3, which you can actually see in our original discussion. So A1, A2, A3. A1 is less than 30 mg per gram. That is your albumin creatinine ratio. 30 to 300 milligram per gram is A2, and more than 300 milligram per gram is equal to A3. When you put it as a ratio, please divide it by 1000 because 1000 milligrams is 1 gram. That's why whenever you write on the case sheet now, how do you write? We say CKD G5 A3 or G3 A2 or G4 A1 like that. So CKD G5 A3 is how we write. So people are used to writing case sheets. It's going to be a jujube question for them. And what is the native kidney disease? That is what you write second. Say for example, native kidney disease is diabetic nephropathy. So you write native kidney disease is diabetic nephropathy. Then you write about specifically the patient having any features of volume overload. So you write whether volume overload is plus or minus. Then you specifically write whether the patient has any features of uremia plus or minus. Then you specifically write the patient has any features of hyperkalemia plus or minus. And then you specifically write whether the patient has any features of acidosis plus or minus. This is how you write on a case sheet. Exactly the same thing they have tested out. Okay, that's question number 2. Question number 3 is a question which I am not happy with because the question setter has not actually given us enough details with respect to this question. It's an incomplete question or a partially framed question, not good on the part of INI to frame such questions. What he has asked is, post-transplant, when you are suspecting acute rejection, what level of creatinine will you do a biopsy? This is the question. First and foremost, post-transplant, when you are seeing an increase in creatinine, rejection is not the first thing that comes to your mind. You will start to look into simple things that you can actually correct, which may be a small obstruction. You may even think of a venous thrombosis. You may think of a dehydration. You may think of a drug, etc., etc. So that's in fact wrong. Now, even if you are thinking of rejection, when will you do biopsy is the question. Now, you are having two types of rejection. One is cellular rejection, and the second one is a difficult to handle humoral rejection or antibody-mediated rejection. As far as cellular rejection is concerned, as per criteria, or if you go with the strict guideline, more than a regular 25% rise from the baseline is an indication to do biopsy if you are suspecting cellular rejection. But if you are suspecting humoral rejection or antibody-mediated rejection, especially if the patient has had a donor-specific antibody positive or it is an ABO-incompatible transplant, so many things are there. If you are suspecting antibody-mediated rejection, there is no value that way, which means that any rise you will actually do biopsy. Correct. So if you're suspecting cellular, it is 25%. If you're suspecting antibody-mediated rejection, then there is no value like that. So if you ask a question, what would indicate rejection, then this is absolutely not fitting into the bill. This is a question which is like kind of, incomplete in itself. So out of the options, Rise of creatinine by more than 10% is suggestive of acute rejection if you ask me. It could be suggestive, but then what kind of question is that? Any rise in creatinine will be suggestive of acute renal allograft rejection. This statement is actually true if you are thinking in terms of antibody mediated rejection, and this statement is actually true if you are thinking in terms of cellular rejection. So if you're thinking in terms of cellular rejection, this statement is true provided this is 25%, not 10%. So more than 10% nowhere it is mentioned. It is more than 25% that you can actually take into consideration cellular rejection. And for antibody mediated rejection, it is any rise in creatinine. Okay, any rise in creatinine, which means that out of these four options, going by what AIIMS generally does and going with the thought process that AIIMS has set this, and this is how we are taught as a nephrology resident, you are always taught that any rise in creatinine, once you rule out all the reversible things, you please do a biopsy, because there is no chance you can take with the patient, because cellular rejection is treatable, antibody mediated rejection is treatable to an extent, but then time is what is equal to gold, diamond and platinum. So because of that, I would mark this as the answer, but again, keeping in mind that this is a question which doesn't have enough details, and this is something which I'm not happy about as a question. If you ask me practical terms, any rise in creatinine, is it significant? Yes, it is significant. Will you do biopsy straight away? And I look into the reversible factors. Those are the most important things for me. I look into the reversible factors. Once I look into the reversible factors, then I'm thinking of rejection, then I'll do biopsy. For any rise in creatinine, I will do, because antibody mediated rejection, then it's a big issue. So for any rise, I will do. But then, and this framed as a question, does it make so much of sense? No. 2-year-old male child presents with fever, hematuria, thrombocytopenia, diarrhea for the last 3 days. So they're basically thinking about TMA, and inside TMA, DHUS or typical HUS or diarrhea-induced HUS. What are the common organisms? We've discussed this so many times. E. coli O157H7, Shigella dysentery type 1. Yes, Shigella dysentery type 1 and Streptococcus pneumoniae. So, E. coli O157H7, Shigella dysentery type 1 and Streptococcus pneumoniae. So, here it is E. coli O157H7. So, it's a very simple, straightforward microbiology with medicine question. Which of the following is not a feature of thrombotic thrombocytopenic purpura or TTP? This is again a question where many people come out with the answer just reading through the books, and seeing what's given in the book. But again, I'm telling you, practical people who teach, who treat patients and who have discussions with the ward are the ones who set questions. So obviously their mindset is not going to be exactly like what you think. So what is TTP? TTP or HUS for that matter, they all come under this heading called TMA, what we call as thrombotic microangiopathy. It's called TMA. Under this heading called TMA, we have TTP, we have HUS, we have preeclampsia, eclampsia health syndrome, we have malignant hypertension, we have scleroderma, renal crisis. So there are a whole lot of things. We have antiphospholipid antibody syndrome. All these things come under this heading called as TMA. What does TMA actually mean? TMA actually means that the whole thing is happening inside a small vessel. So that's very important. It's happening inside a small vessel. In a small vessel, say for example in HUS, you are having an endothelial injury. And so whenever there is an endothelial injury, large amounts of von Willebrand factor are being generated from the injured endothelium. This von Willebrand factor will bind to collagen here in the subendothelium and will trap platelets, okay, on the other side, because platelets are being attracted via GP1B9 and a platelet plug is being formed inside the small vessel. And when the platelet plug is being formed inside the small vessel, because you're trapping platelets, you will get thrombocytopenia. And when the other RBCs are trying to course through this, then the sides of the RBC gets chopped off. So you get hemolysis. It is happening in the small vessel. So it's called microangiopathic hemolysis. So we have microangiopathic hemolytic anemia and thrombocytopenia as a common factor in everything. You have this as a common factor. Then depending on the cause, the other factors can actually change. What is the difference between HUS and what is the difference between HUS and TTP if you ask me? In HUS, the problem is that you are having endothelial injury. So that is a problem in HUS. Endothelial injury can be because of the Shiga toxin or can be because of this E. coli O157H7, all that is there. Now, TTP is because of anti-ADAMS13 antibody. So what is this anti-ADAMS13 antibody? It is against ADAMS13. So what is ADAMS13? ADMTS13, that is a von Willebrand factor metalloproteinase. It will cleave the von Willebrand factor. So if that is not being cleaved, then automatically what will happen? You will have this sitting on the circulation and again causing something like a thrombus by trapping more and more platelets. So TTP is like this, HUS is like this. So you know this is the essential difference. Then what is the clinical difference between HUS and TTP? What are we taught in our wards? The clinical difference between HUS and TTP is that HUS happens in the kidneys. That's why it's dealt with by the nephrologist. TTP happens in the brain. That's why it's dealt by the neurologist. You can get TTP symptoms, CVS, GIT, of course, but the predominant symptoms are going to be neurological, and in HUS it is going to be renal. That's why nephrologists are discussing length and breadth about HUS. Neurologists discuss a lot about TTP. So what is HUS if you ask me? HUS is MAHA with thrombocytopenia with renal failure. Okay, this is what is called as HUS. If you ask me what is TTP, then I will say MAHA with thrombocytopenia with neurological symptoms. Okay, with neurological symptoms. This is called TTP. But then traditionally in textbooks and so many of the other authors and all have used this term called pendad of TTP. Now what is the pendad of TTP? They have added fever because it is almost always present in TTP patients and renal. But renal involvement in TTP is actually speaking very rare, very rare. Okay, it's not at all common to get renal failure in TTP. In fact, incidence wise and all you see is 3%, 2%, etc. So both these options are right. Then both these options are right. Thrombocytopenia and MAHA. Which one will you mark? This is not a good question, first of all. If you're asking me thrombosis, this is exactly thrombotic microangiopathy, which means small vessel thrombosis. They have not mentioned large or small here, so I don't know whether to take it as right or wrong. Renal failure is like yeah, kind of an S, but then it's not classically seen in TTP. So you can mark either of the two options. That's perfectly fine. Both are actually in a way correct when you mark. I don't know what they are thinking about, but going with again the mindset of the setters in AIIMS, I would have marked renal failure in this because renal failure is always for HUS and not for TTP. This is what we are taught at a basic ward level. But if you are asking me, is thrombosis correct? Thrombosis is definitely incorrect if you're talking of large vessel thrombosis. But if you're telling me small vessel thrombosis, then it is always seen. So they haven't mentioned thrombosis. Some people say that when you say thrombosis, it means large vessel. I'm not sure about that. So either way, you can take it whichever way you want, but I'm telling with my gut feeling. My gut feeling is that we're looking for renal failure because that's something which is elementary and we are taught again and again and so many number of times that HUS is for renal failure and TTP is for neurological. So I would have marked renal failure, but nobody can raise any doubt or raise any questions or eyebrows against you for marking thrombosis because as you said, large vessel thrombosis is not seen. But I am thinking thrombosis can be any vessel. So in that case, I would mark renal failure. Again, not a good question. Okay, so but you expect to get few questions like this. That's just part of the game. So just take it in its stride. We are not getting too many questions that way. Then comes what causes a decrease in GFR? A very simple, stable question which everybody would love to answer. So this have been discussing, I think, from time immemorial as GFR is equal to net ultrafiltration pressure into ultrafiltration coefficient. So ultrafiltration coefficient into net ultrafiltration pressure. Okay. So what is ultrafiltration coefficient? What we call as KUF. And what is net ultrafiltration pressure? That is equal to net hydrostatic pressure minus net oncotic pressure, correct? So KUF into net hydrostatic pressure is capillary hydrostatic pressure minus Bowman space hydrostatic pressure minus oncotic pressure is how much? That is equal to capillary oncotic pressure minus Bowman space oncotic pressure. That's it. Now if you just fill the values, it's fine. 12.5 is your KUF or ultrafiltration coefficient. That into this is ml per minute per mm mercury. ml per minute per mm mercury. This is 60, this is 18 and this is 32. 60, 18, 32. So net ultrafiltration pressure will come to 10 millimeters of mercury and that's how your GFR comes to 125 ml per minute. So it's basic physiology calculation. So what can cause a decrease in GFR? Glomerular capillary hydrostatic pressure increase will cause increase in GFR. Bowman space hydrostatic pressure increase will actually cause a decrease in GFR. Similarly, glomerular capillary oncotic pressure increase can also cause a decrease in GFR. So that's why increase in glomerular capillary hydrostatic pressure will always increase the GFR. Decrease in Bowman space hydrostatic pressure will always increase the GFR. The glomerular coefficient, no coefficient is there like that. I think they mean ultrafiltration coefficient. So decrease in glomerular coefficient, there is no coefficient like that. Decrease in glomerular oncotic pressure. Glomerular capillary oncotic pressure, if you have that, when it decreases, is automatically equal to increase in GFR. So this is also going to cause an increase in GFR. Decrease in glomerular coefficient, I don't know if there is a coefficient like that. They are naming their own coefficients. Maybe I think they mean ultrafiltration coefficient. Maybe in some book somewhere it would have been named as glomerular coefficient. I have not read anyway. So this is the basic theory. Out of this you see the option. We don't know whether these are the exact options, but just keep in mind whenever glomerular capillary hydrostatic pressure increases, of course GFR increases. Bowman space hydrostatic pressure decreases, GFR increases. Glomerular capillary oncotic pressure increases, again GFR decreases. And Bowman space oncotic pressure is negligible, or that's basically equal to 0. So this is essentially what is equal to this question. Fine. Then 25-year-old male comes with hematuria. Um, which of the following is seen in glomerular hematuria is what they are actually asking you. So, what is the meaning of glomerular hematuria? I've told this I think 100 times. Glomerular hematuria is equal to 40-5-1 rule, right? 40% or more when you are having dysmorphic RBCs, or 5% or more you are having acanthocytes. So, 40% or more dysmorphic RBCs, 5% or more acanthocytes, or even one single RBC cast. One single RBC cast. This is what is equal to glomerular hematuria. And hematuria is a term that we use for high colored urine, which can be brown colored urine, red colored urine, cola colored urine. So this is fine. Dysuria absent. Yes, dysuria is generally absent. There is no reason for you to have dysuria. Then crystals present. Crystals are not present. Crystal has got nothing to do with glomerular hematuria. This is the rule. Edema rare depends on the original cause, because glomerular hematuria is a very general term, right? Glomerular hematuria can be seen with PSG and glomerular hematuria can be seen with IgA nephropathy. So when you see a child with IgA nephropathy for the first time, is he having edema? No, he's not having edema. When you're having a child with PSG and seeing him for the first time, does he have edema? He has intravascular edema, not much of extravascular. Extravascularly, he is not having too much of edema. So that way, edema is rare is also a term that you can mark as correct. So A, B, and D you can mark as right. Just to know the basic approach to how you kind of get on with a renal problem that we have discussed in so many modules. So I think this is also a pretty easy question. This has a definite answer. The two questions in nephrology which I feel could have been made better are these two questions, where they should have actually kind of given more details or given more data. First of all, asking a question on transplant is not right, because none of you have any exposure to transplant at undergraduate level. But even if you ask something that should be a concrete question, this is a concrete question where two options are like kind of coming into picture, which doesn't really make sense. Had they mentioned large vessel thrombosis, then that would have been taken as a wrong option 100%. Had they mentioned small vessel thrombosis, we could have taken it as a right option and then marked renal failure. So those are the only two questions. Otherwise, everything seems right on track. This is to show you an RBC cast. This is to show you what we call as the dysmorphic RBC. This is the isomorphic normal RBC and the crenated RBC, which you see in urological causes. This is dysmorphic RBC. This is the Mickey Mouse RBC. Mickey Mouse RBC is what we call as your acanthocyte. And this is your renal tubular epithelial cell, which we have discussed so many times. So that's about nephrology for this exam. Pretty decent, but two questions which we are not quite happy with. Let us go to endocrinology and metabolism, which is the other major chapter as far as the exam is concerned. So Pheo is something where we expect to get a question. You should be knowing everything about Pheo. There is no excuse for not knowing anything about Pheo, especially if you're following my videos, because I'm somebody who is in love with Pheo. I have discussed everything about Pheo and I've discussed something that's actually above what is required for the exam. So what is Pheochromocytoma? Which of the following will be the preferred first investigation? So naturally, screening investigation for Pheo is 24-hour urine fractionated metanephrine. No more talks on that. We have discussed this umpteen number of times. Sensitivity and specificity both are 98%. After doing urine fractionated metanephrine, if you feel that okay, I need a test with 100% sensitivity to definitely rule this out, you can do plasma fractionated metanephrine. Otherwise, the screening test is always 24-hour urine fractionated metanephrine. Then we go to the imaging investigation. Initial imaging investigation is the MRI abdomen. Even if CT is there, that's fine, but MRI is the better one. After that, if you are not able to find the mass and you want to look for other extra-adenal sites, previously it was MIBG, now it's not MIBG, it is gallium dotatate scan. Okay, so that we have discussed so many number of times. Nothing much to talk on that. Second question, adrenal medulla, is which of the following does not stimulate catecholamine synthesis? There are 1,000 things in this world which will stimulate catecholamine synthesis. Naturally, the most important one is hypoglycemia. So, of course, hyperglycemia can never stimulate catecholamine synthesis. It's a stress response. So, naturally, hypoglycemia, everybody knows. It's a very easy question, but please go back and see the discussion on the initial part of adrenal medulla. We've discussed the physiology part of adrenal medulla, where I have said about standing, where there is a decrease in intravascular volume, of pooling, plus exercise, smoking are all things which can actually stimulate catecholamines. Also a physiology question to match with the receptor. Our first module is entirely with respect to this. So this is the correct match. Insulin is tyrosine kinase, acetylcholine is ligand gated, growth hormone and prolactin with EPO are JAK-STAT, thyroxine is nuclear receptor, and we've done the group 1 hormones, group 2 hormones, group 1 hormones, then intranuclear, intracytoplasmic, then group 2 hormones, cyclic AMP, IP3DAG, everything we have discussed. That's the first of the modules. Please go and watch that in detail. Female patient comes with type 1 DM and hypoparathyroidism, presenting with chronic mucocutaneous candidiasis, diagnosed as APS. So this is a question which again I felt they should have made a bit more better. This is one of my favorite topics, and I've discussed this case about a sister in our ward who had Graves' disease for a long time but who continued to get tetany. And then I just called up my chief, Sridhar Madhavan sir, now HOD at SRMC in Chennai. There is a female who is about 25, 30 years old. She's a staff nurse. She's been diagnosed already as Graves' disease and taking carbamazole for the same with beta blockers, but continuing to get hypocalcemic episodes. So then he said over the phone that this is mostly APS1. And I think I've shared this also. So then I got shocked, sir, how? So then he said hypercalcemia generally goes hand in hand with hyperthyroidism, and hypo goes hand in hand with hypothyroidism. So here we're having a combination wrong. No? Hypocalcemia with thyrotoxicosis or hyperthyroidism is most likely to be APS1. So that's exactly what is APS1. APS1 is called autoimmune, this is called as polyendocrine syndromes. This is the old name, PGA, polyglandular autoimmune syndromes or autoimmune polyendocrinopathy syndromes, whichever way you want, you can call it. Now, this has got two types. Type 1 is what we are talking of. Type 1 is also called by two names. This is the autoimmune regulatory gene defect, okay? And it is also called, this name I have actually stressed on because I knew this is a question. Autoimmune polyendocrinopathy with candidiasis and ectodermal dystrophy, that is called APECD. That's why from childhood these people have candidiasis, ectodermal, skin and nail changes, etc. etc. That's the point. And type 1 starts very early and type 2 starts in adulthood. So type 1 starts very early. The three cardinal features that if you want to point in type 1, which will you point? Of course, thyroid is the first one, which is most often a Graves here as we have seen. Second is hypoparathyroidism, which causes hypocalcemia as you have seen. And Addison is the third. So these are the three most important manifestations. Other two manifestations include type 1 DM and hypogonadism. These are the five major things, of which these are the three most important, and two more things are type 1 DM and hypogonadism. This much I have taught in class, so everybody knows this much. But the question was like little. Type 1 DM association is high, starts in infancy, hypoparathyroidism seen, high association with candidates. This everybody knows is right. This everybody knows is right. Starts in infancy is a little tricky because actually speaking, if you go with the original data, childhood is an answer, but then Harrison table does say infancy. So probably you have to take it as right. But type 1 DM association high is anyway not right, because type 1 DM association percentage wise I knew is like on the lower side. Then I checked it up and found out that this is 23% as per the new data. So new data, new edition endocrine books say 23%. So it's not like very high. So some people unfortunately mark the answer as starts in infancy because I kept on saying child. I never said infant. In fact, I have also not seen any infant having type 1 APS. Whomever we have discussed, and all are 3 years, 4 years like that. But unfortunately, the table again I have shown in class, it's starting as infancy, okay? But type 1 DM association high you should never mark, because you said the three most important associations are Addison, Graves, and of course hypocalcemia. So that's why I think majority of them got it right, but for few people thought like this is child and have been wrongly given as infancy, and that's like partly wrong on my side also because I kept on saying child. But still I think if you've had the sense to think that type 1 DM is not that common, probably would have got the question right. So it's a standard question, little on the tougher side. All are part of name syndrome, part of Carney's complex. I've told, men, meon, Pheochromocytoma, and all are like every day you keep getting questions. In this exam also, did you get a question on Pheo? Yes, you got a question on Pheo. Did you get a question on men? You got a question on men. Did you get a question on PGA? You got a question on PGA. Did you get a question on meon? Yes, this is the question on meon. I've shown you all the meon syndromes, right? Hyperparathyroidism, jaw tumor syndrome, Carney complex, von Hippel-Lindau, neurofibromatosis 1, Cowden syndrome, McKeown-Albright syndrome. These are all the multiple endocrine and other organ neoplasia syndromes, what we call as meon syndromes. And when we talk of meon syndromes, when it comes to Carney's complex, what did I tell you? What is the endocrine part? What is the neoplasia part? Neoplasia part we have discussed so many times is equal to myxoma, atrial myxoma. So atrial myxoma is so classical with respect to the neoplasia part. Then when it comes to the endocrine part of Carney's complex, what do we say? We say adrenal Cushing's, correct? Adrenal Cushing's. You can get acromegaly, prolactinoma, etc. in Carney's complex, but the most important part is adrenal Cushing's. What type of adrenal Cushing's? Primary pigmented nodular adrenal hyperplasia. Okay, or primary pigmented nodular adrenal disease. This is also an example for what we call lean Cushing's. And this is also an example of what we call cyclical Cushing's, all that I have discussed. So primary pigmented nodular adrenal disease. So adrenal Cushing's, so adrenal mass is the other endocrine thing. So that's it. So now they've come to this question where they've asked you about this name, or where N stands for nevi, A stands for atrial myxoma, M stands for myxoid neurofibroma, and E stands for the endocrine manifestation. So instead of that, they have given Epstein anomaly, and Epstein anomaly has nothing to do with your Carney's complex. If you watch the video, it's a very simple straight big question. Please study everything about meons, okay? Don't get a question wrong on this, next time also definitely they'll ask you. Same about men to be also. Every time we keep on studying men 2A, 2B, 2A, 2B. So what do we study about this? You have Pheochromocytoma in men 2B. Yes, you have Pheochromocytoma in men 2B. Along with that, what do you have in men 2B? You have medullary thyroid cancer. Yes, medullary thyroid cancer, which is seen in nearly almost 100% of patients. And along with that, in men 2B, you are having the 4Ms. Yes, the 4Ms. What are the 4Ms? Medullated corneal nerve fibers, megacolon, Marfanoid habitus, and mucosal ganglioneuromatosis. So this is basically the 4Ms that you're actually talking about. But now there is a small change in nomenclature. We are now kind of making the nomenclature a little bit different, as you can see in the video. But generally, this is what we study. And this was the original nomenclature, made a little different here and there. So please do keep in mind medullary thyroid carcinoma, Pheochromocytoma, which goes hand in hand for men 2A as well as 2B. In 2A, the other variants are men 2A with parathyroid involvement, men 2A with cutaneous lichen amyloidosis. Those are the variants. That's why parathyroid is almost always part of men 2A. And of course, it's part of men 1, but it's got nothing to do with men 2B. 2B is all about these M's, where you have megacolon, you have Marfanoid habitus, you have mucosal intestinal ganglioneuromatosis, and you have medullated corneal nerve fibers. Okay, so please go and watch the videos in detail. Men, Meon, TGA, very, very, very important. Of course, Pheo as well. Then we have generally, like, INI doesn't go away without asking a question on prolactin as well as a question on calcium. So prolactin, they have given a physiology question. I'm not discussing it here. It's about prolactin causing hypogonadotropic hypogonadism. We've discussed that, right? Prolactin causes suppression of the axis, so it does produce hypogonadotropic hypogonadism. They've asked a question on calcium, which is a lab kind of a question. Yes, lab kind of a question. Now, we have discussed this so many number of times that calcium as well as H plus will compete for binding to albumin. This is the basic theory. So whenever you are having acidosis, then you are having hypercalcemia, because more of H plus will bind to albumin, free calcium will increase. So acidosis and hypercalcemia, alkalosis and hypocalcemia. So never allow acidosis, because that can alter your calcium levels. So collecting after exercise, making of fist, etc. are all leading on to what? Acidosis. That's why that is basically not recommended. So which of the following should be prevented? Making of fist is not recommended, is the right thing. Collecting after exercise is a wrong thing. A tourniquet being tied very tightly and causing venous stasis again is not the right thing. And staying immobilized, of course, can actually lead to bone resorption and increase calcium levels. So this is the right statement. Making fist is not recommended is the right statement. Collecting after exercise is the wrong statement. Tourniquet is needed, tie and release as soon as sample is collected is the right statement. This is more of a practical lab question. But nobody has taught this. I have not come and told you, okay, these are the protocols for taking calcium. No, I have not said that way. But you should have the basic idea that calcium and H plus will compete for binding with albumin. Acidosis can actually cause a problem. Alkalosis can also cause a problem. So if you apply that, then it becomes a more easier question. Yeah. Diabetes question, which we have discussed so many number of times. Insulin stimulates everything in the body except for something that is not stimulated by insulin, and that is hormone sensitive lipase. We really don't want hormone sensitive lipase. Hormone sensitive lipase is the killer, because that is the one that leads to lipolysis. That is the one that leads to uncontrolled free fatty acids. When you are having centripetal obesity, what is the problem? You are having centripetal obesity, alpha to beta 3 receptors will change. Beta 3 causes increased lipolysis. Increased lipolysis leads to increased free fatty acids. Free fatty acids here will straight go into the portal circulation and straight enter into the liver. That's why having abdominal obesity is far more dangerous than having obesity at the back. So when these free fatty acids enter into the liver, what is the problem? They cannot enter into the mitochondria, because there is no carnitine palmitoyl transferase being expressed. So these free fatty acids will undergo two things. One, it will result in gluconeogenesis, and that will release your or increase your hepatic glucose production. Second is that these free fatty acids will actually go and become fatty acyl CoA, and that is promoting insulin resistance. So who is the villain? One of the major villains in diabetes is hormone sensitive lipase. So does insulin promote hormone sensitive lipase? Never. It will want to always inhibit hormone sensitive lipase. It promotes all the other enzymes in the body, all the other reactions in the body for that matter, but hormone sensitive lipase is something it will always inhibit. Okay, so increased action of lipoprotein lipase, decreased action of hormone sensitive lipase. So this is about endocrine and metabolism. We had one question on gastronoma also. It's more of a surgery question, the triangle part, Passaro's triangle. And then of course we had one more question on gastrin secretion and all that. It's all very easy. So essentially endocrine questions very much easy this time, nothing much. The only doubtful question was the PGA question, PGA or APS question, which again also majority people got it right. And this question on calcium methodology, which many people thought is beyond their level and left it and come, had they kind of applied a bit of what they had studied, I think this would also been easy. Let's go to rheumatology. Which of the following cannot help in differentiating psoriatic arthritis from other forms of arthritis? This is Like we have studied about RA versus your seronegative spondyloarthropathy, so spondyloarthritis as we call it. And what have we learned? Asymmetricity, enthesopathy, dactylitis, nail changes, HIV association, these are all part and parcel of the spondyloarthritis. Inside spondyloarthritis, when you talk of enthesitis and dactylitis, what have to come to your mind, or who has to come to your mind? Reactive arthritis and psoriatic arthritis have to come to mind, of which enthesitis is something that we always talk also in terms with respect to your ankylosing spondylitis. Nail changes, huge topic for discussion in psoriatic arthritis. So dactylitis, enthesitis, nail pitting, all part and parcel. Presence of diarrhea is of course something which you will be easily able to rule out. So once again, the topic is spondyloarthritis. We get questions on spondyloarthritis every single time, and we have discussed at a very higher level. We have discussed at a higher level because for the exam we can only answer questions which are much below the level at which you have studied. Otherwise, it's not possible. So that's it. Then a question came on HLA-B27 and ankylosing spondylitis also, which I think everybody would have answered. Then, yeah, this is the question. Enthesitis, sacroiliitis. So this is HLA-B27. Let's come to this question, which of course I have taught very clearly, crystal clear. I don't know, some people got it wrong. Behcet's disease, what is not seen? Behcet's disease is called oral ulcers. That is a synechion manifestation. Alongside with that, you need 2 out of 4. What are the 4 things? You have pathology test 1, you have skin lesions 2, you have ocular 3, you have genital 4. It's very clear. That is the classification criteria. This is the international study group criteria, and again exactly that's what we have actually discussed. Okay, now so yeah, when it comes to genital ulcer, what is the difference? That's what I've been trying to teach you all the time. Genital ulcers always spare the glans, penis and urethra. They spare the penis, they don't generally involve the glans, penis. So that's why ulcer over the dorsum of the penis is the wrong option. And Crohn's and Behcet, I think I have told myself 10,000 times. Whenever I talk of Crohn's, I say Behcet. The original opening slide on Behcet itself is like with respect to Crohn's. Yeah, bilateral pannivitis, ocular manifestation, chronic bilateral pannivitis, sarcoid and Behcet both are associated with pannivitis. Pathology test positive is a criterion. So it's a slightly tough question, but you've heard the video on Behcet because it is a variable vessel vasculitis and we've discussed in detail about Behcet. I think you should be able to come out with the answer in this question. So recurrent painful oral ulcers anywhere in the oral cavity, but not like that in genital cavity. Starts as erythematous papules or pustules which break down into shallow ulcers, heal without scarring. Okay, painless ulcers are mostly associated with SLE, and when you come back to the genital part, then the difference is that they are actually less painful, they are more recurrent, they are more deep, they heal with scarring, and of course, they spare the penis and urethra. Clear? Yeah. Then this is a straightforward question. Then we come to, yeah, what is the pattern of ANA? So many times pathology have been taught this. I have also tried to hint on this. The last recall in May I have again talked on this. You have a question on ANA pattern. This is looking like a speckled, but the metaphase cell is positive. So when the metaphase cell is positive and it is looking like a speckle, then it becomes a centromere pattern. So that way you can study. But in the original question that we did get, okay, there was a case of Raynaud's phenomenon. So whenever somebody has actually presented with a Raynaud's phenomenon, that too significant Raynaud's phenomenon with significant critical limb ischemia, then that is mostly going to be a limited systemic sclerosis, because the presentation of diffuse systemic sclerosis is not with such a significant Raynaud's. We've seen the difference in presentation between limited as well as with diffuse. So limited is the one which over a short period of time gets very bad. It's a Raynaud's lasting for a long time, but over a short period of time it gets very bad and you have features of critical limb ischemia. So that itself means that it is limited. So whenever limited comes to mind, naturally which syndrome has to come to mind? Crest has to come to mind. And there you have esophagitis, there you have calcinosis, there you have sclerodactyly, and there you have telangiectasia, and there you have Raynaud's phenomenon. So I believe some of the students were saying about the fact that telangiectasia was there in the question. There is also something about swallowing issues and etc, etc. So most likely this is a case of centromere pattern. So I feel that this is a question where even if you don't know how to read the pattern, in pathology you've been taught how to read the patterns, and I have told you about what pattern is seen where, but I haven't gone to the extent of teaching you how to read the patterns. But we have done that in the last recall video, May 23 recall. You can actually see where we have tried to do that. But then the fact is that even if you don't know this, you're thinking of a Raynaud presentation with a significant impairment in terms of your ulcers as well as with respect to pain and all that, critical limb ischemia, then it is a part of limited systemic sclerosis. Limited systemic sclerosis for your exam is almost always associated with Crest syndrome, and in Crest syndrome we have anticentromere. If you say homogeneous pattern, you know it is SLE, 100% wrong. Nucleolar pattern is PMSCL70. PMSCL70 should have something with respect to polymyositis also. And speckled pattern systemic sclerosis is again wrong, because speckled pattern is again fine speckled pattern, coarse speckled pattern, And there are so many things inside that, and we have discussed that in detail with respect to what pattern stands for what, etc. Because generally when you say spectral pattern, you're talking in terms of a fine spectral pattern, then mostly this roll eye, everything comes to mind, just Jogan, it's a different thing altogether. So even if you don't know the actual interpretation of this diagram, in spite of that, you will still get away if you know the fact that RP severe is limited, and that is part of crust. That's all. So topoisomerase 1 antibody is where you are actually talking in terms of your diffuse systemic sclerosis. RNA polymerase 3 is also more part of your diffuse systemic sclerosis. We have a few questions in hematology as usual, but this time around hematology questions were very, very, very easy. So we have numbness, Romberg's dispositive, broad-based gait, and this is all part of your sensory ataxia complex. Sensory ataxia complex is an important discussion in neurology, important discussion in hematology. Sensory ataxia complex, sensory neuropathy should always make us think of something like a B12 deficiency. And we discussed how to differentiate between Friedreich's ataxia, B12 deficiency, tabes dorsalis, how does ganglionopathy differ from a sensory kind of neuropathy. All that we have discussed in detail. And here the answer is B12 deficiency, because again they have given a clear history of gastrectomy, which makes the answer very easy, as intrinsic factors produced from the stomach. So you can learn this at a very basic level, but if you know a little bit more advanced, you get more confidence. This is a clear, straightforward question. Child means, of course, you're thinking of AL, CD 19, 20, 21, 22, everything is in terms of B cell AL. So this is the typical BAL that you talk of in children. Then hereditary cause of thrombosis, again, if you mark this answer wrong, then I mean, nothing to tell you, because I'm a person who's been telling you this 100 times. PNH is again one of my very favorite topics. My close to heart topics, many of them have been touched over here. PNH is one such topic. I've talked about my main legendary teachers in PNH like Neelas Young and all of them. PNH is the most important cause for acquired intravascular thrombosis. Then inherited coagulopathy, again factor V Leiden mutation, which we have mentioned again so many number of times. There was a question on all the factors being everything PTA, everything being normal, and you have umbilical stump bleeding, clot solubility test, that is factor 13 deficiency. Even that was asked for your exam. Hemolytic anemia, we have again talked about urobilinogen being high. Transaminases are not high. Ferritin can be high. Conjugated bilirubin, it is unconjugated bilirubin. Indirect Vandenberg is what is basically equal to unconjugated bilirubin. So that is basically high. We have discussed about intravascular and extravascular hemolysis, how to differentiate between the two. In extravascular hemolysis, heme and globin. Globin goes to the amino acid pool. Heme is broken down into iron and protoporphyrin. Iron goes into the ferritin high zone. Protoporphyrin will be broken down into bilirubin. And bilirubin will be converted into urobilinogen in urine. Intravascular will be equal to direct destruction, which can lead on to hemoglobinuria, hemosideриnuria, etc. So all that we have discussed in detail. So this is the core, these three chapters as far as this exam is concerned. These four chapters, rheumat, endocrine, nephro, as well as your hematology. Remaining topics have been touched upon here, there, etc. Let us try to see those questions as well. Now, this is a slightly tricky question, because Strindberg pattern indicates endobronchial involvement, which can be seen in any infection, though TB is the first thing that comes to mind. 30-year-old immunocompetent person comes with weight loss and cough, means again TB comes to mind. Pleural effusion, again TB comes to mind. Then ADA is low, it's like almost a no for TB. Lymphocytes high, which is again good for TB. What are they going to get is the question. So this question, when it popped up after the exam, many people give different opinions. So one group believe that fungal hyphae is there where you can get lymphocytes. Another group thought it can be a reactive hyperplasia, and some people believed it is still TB. As far as I am concerned, for anything in this country, if you ask me whether TB is possible, I would say TB is possible. For any question that is being asked for your exam, if you're asking me differentials, I would say TB is possible. Just because ADA is low, although ADA is a test with high sensitivity, I do understand that young patient, immunocompetent patient, pleural effusion, lymphocytes are present, and there is Strindberg. And if you don't say it is TB, then you are not studying in India. So that is as simple as that, no more. Okay, this is a case of a diabetic patient, fever, malaise and productive coughs. It's like curve 65 they asked last time. This time they changed the question. What do you see in pyogenic pneumonia? Do you get patchy infiltrates? No, you get lobar consolidation in pyogenic pneumonia. That is what we always see. Interstitial pattern is what we see in viral pneumonia. Hilar adenopathy with infiltrates can be seen in malignancy. That's perfectly right. Aspirational pneumonia is more common in the upper segment of the lower lobe and the posterior segment of the upper lobe. All these things you know, but patchy infiltrates are never part of pyogenic pneumonia. You can get, but it's never like seen. Generally, we say no. And mycoplasma is the cause of interstitial pneumonia. We've seen the organisms causing lobar pattern, interstitial pattern, everything. This is the classical epsilon wave. So many times I've shown you this. This is the epsilon wave. This is the epsilon wave. This is the epsilon wave. Epsilon wave is part of what we call as ARVD. And this is again a part of our ECG discussion, certain important catch waves, delta wave, epsilon wave, like that. And epsilon wave brings to mind one of greatest players that England produced. Not to say greatest player, but he was like evolving into a star, James Taylor. So I think some of you may be knowing James Taylor from Leicestershire. He made his debut for England, I think somewhere around 2012 in South Africa series, and is a very promising cricketer. Promising cricketer who almost rose to stardom. He was part of England's team for the 2015 World Cup as well. And in 2016, we suddenly came to know that James Taylor is stopping his career all of a sudden. I think about 25 years of age at that time, and we didn't know the reasons. But later on, it has come out that he was diagnosed to have ARVD, and that's why he was advised not to play anymore. Okay, so that's about it. Then we have this question on, celiac. Celiac is something I've taught you so much, like I don't want to discuss anything more here. It is like DQ2, DQ8. I've been telling this so many number of times. What is called latent celiac, what is called silent celiac, what is called atypical celiac. Celiac is what we see as GI is classical celiac. Atypical celiac can present in so many different ways. We've discussed about cerebellar. We've discussed about iron deficiency anemia. We have talked about simple ataxia. We have talked about growth retardation in children and all that. Then we talked about silent celiac, where only the antibodies are positive, and latent celiac, where even the antibodies are not positive, but DQ2, DQ8. So if you want to rule out that it's DQ2, DQ8, if you want to remember on HLA for the exam is also DQ2, DQ8. So celiac, I think we have discussed enough and more, more and more. Yeah. Two questions on ulcerative colitis. JAK inhibitor used in ulcerative colitis. I mean, I have taught you about the treatment of ulcerative colitis, and JAK inhibitors are like the last line. But upadacitinib, tofacitinib, the names you have mentioned, even RA also, we do have some role for small molecules like JAK inhibitors. And True and Witt's classification of ulcerative colitis to actually gauge the severity. And I mentioned this so many number of times. It's a very important classification. Whenever we talk about UC, so the name is something that we try to highlight. True and Witt, I think I've told this n number of times. So gastro and liver, there is absolutely no mercy for getting questions wrong, because those are like extreme easy to answer. Like I am so confident that it's hard for a person to frame a question in gastro outside what I have taught. It's very hard. It's easy for a person to frame a question in neurology or cardiology outside what I have taught or outside what anyone has taught, because it's so vast. It's so vast. It's like not possible for anybody to teach them in total, but that's not the case with gastro. Okay, neurology representation was pretty poor this time. We had only a question on GBS. There was a child question discussed by Singaram. That was a simple question. This question is a very practical question. You need not actually know anything. We have discussed this, but anybody who has worked in a casualty will know this. To thrombolize a patient, you need to bring the BP down to less than 185, 110. This is the cutoff number for thrombolysis in an ischemic stroke, which means that you are basically looking to bring the BP down to 185, 110 or less, and not less than 140, because that will further compromise on the cerebral perfusion pressure, and that can increase the infarct size. So BP should be reduced less than 140, 90 is a blunder which everybody knows. So 100% everybody would have got this question right. But if it is a hemorrhagic stroke, can we try for a BP reduction less than that? 100%. Hemorrhagic stroke, we are generally trying for a BP reduction less than 160, 100, or somewhere between 140, 90 to 160, 100. If you are not planning for thrombolysis, what level of BP should you treat? Generally, the BP that we see in stroke patients in our hospital, we need not treat. Only if it is more than 220, 120 that you are actually going to treat. So 220, 120 and above is only what you plan to treat if you're not planning for a thrombolysis. If you're planning for a thrombolysis, 180 by 110 is what you must be trying to treat. And if you're having a hemorrhagic stroke, you can try to achieve slightly more BP control. In an ischemic stroke, cerebral perfusion pressure is equal to mean arterial pressure minus intracranial pressure. So MAP reduction, approximately 25% is what you have to try. Nothing less than that. I mean, nothing less than that. So multiple recording should be taken. That's like common sense question. Aggressive use of IV antihypertensives in hemorrhagic stroke, perfect. And reduce the BP to less than 760, 100. Even up to 140, 90, you can try. But somewhere between 140, 90 and 160, 100. Okay, this is the only one question on neurology that I did get. There was another question on what is not seen in LMN and human, also basic, simple question. And of course, a question on GBS, childhood GBS, which is also very easy because it is giving right options straight away, like IVIG, albuminocytological dissociation, air reflex is part of criteria. And then they've said that Plex can be used only for resistant kind of things. No, Plex can be used as first line, so there is no harm in that. So those are the kind of questions. Even more than this, we did have one or two questions here and there. Physiological dead space they've asked for, which is alveolar plus anatomical dead space. So physiological dead space increases when there's a perfusion problem. So air gets trapped there. So ventilation is okay, but perfusion is not happening. We had questions on primary versus secondary transports. active and passive, I'm saying. So secondary active transport is only one active, rest we are all passive. So we have so many questions like that, which are all physiology, biochemistry, anatomy, pathology, but like all integrated one way or the other with medicine. So elderly people have decreased complaints. So that's the reason why they have increase in systolic pressure alone. So the other questions include GBS and HIV, which I told you. Nocardiosis was asked, which is something which we discussed even in the revision videos. I've done a small bit on nocardiosis about its filamentous nature, partially acid fast, nocardiosis causing pneumonia and all that, nocardiosis causing skin lesions as well. Malaria treatment was a slightly tricky question. Primaquine, I believe, is the answer, because if you don't have access to artemisinin or artesunate based combination therapies, then you can always try giving chloroquine in uncomplicated malaria. That's what the data says. This is not what we're doing in routine practice. In routine practice, we are not thinking of alciparum or any kind of Vivax and stuff. We're thinking of a complicated and uncomplicated. Uncomplicated means we give oral artesunate combination therapy with lumefantrine, and complicated means we give IV artesunate. So that's what we do practically. From a community medicine perspective, malaria treatment question, I think primaquine is the answer, and one or two questions on gastronoma as well, which are all pretty easy. So on the whole, I believe this paper is a doable paper, very, very doable paper. If you scan through the entire medicine questions, there are hardly 4 or 5 questions where we do have a doubt, and we tend to blame the examiner also. Like, you would have framed this question better, like a TTP question, like the transplant question, or maybe those 1 or 2 questions here, and the rest of the questions are all very easy. I believe the topper is going to get somewhere close to 190 this time, because there isn't nothing much preventing him from getting all the questions right. So what does it mean? INI-CET November is a definite realistic target. It's a realistic target. You can plan for it, even May you can plan for, but remember that May not be exactly as how we predict. And don't try to study overboard, just know the basic facts very clearly, but do understand that the final 10 or 15 questions that will help you cross the bar and get a really good rank does come out of your extra bit of knowledge. That's what helps you to answer more confidently. Toughness of the paper does make competition stiff. Yes, it does make competition stiff, but then we are here to compete. We are here to compete. There are no half measures. There are absolutely no half measures. You are trying to give it your 100%. That is what the attitude has to be with respect to the exam. After the exam, whether you choose radiology or medicine, or you don't choose medicine and choose something that's more easier for your personal life, that's 100% acceptable, because many of you may be good at studies, but when it comes to being at the center of a storm and trying to manage everything in the hospital, talk with 100 other people, have stress every day, think about the revenue that you generate, think about the bystanders, think about how to communicate. So you are actually inviting a lot of stress by coming into a space like medicine, so that you can easily avoid. You can take something like radiology, which makes you more happy. That's 100% justified. But when you give the exam, you're always giving with vengeance, or you're giving with the zeal, with the vigor that you have to be cracking and getting into the top spot. So keep working hard towards a seat, and that should make you proud. Now, why I'm telling you this is because this seat is something that will be remembered all your life. I wrote the entrance exam 10 years ago, but still, even now, always we have this in our mind. No, you got this much. That rank is not the exact number, is not what that matters, but what you did with that rank. So that life-changing part, no, because it's a rate-limiting step in our whole career. MBBS, MD, DM, 3 entrance exam that I have written, this is the rate limiting step, because this is what determines how your career is going to take a turn and towards where is it headed to as such. So in that regard, this exam is mighty important. So you will always remember what you did with that rank. If you become a radiologist, that's because you got that rank. I got into a college which had a good clinical exposure, which gave me a platform to express out myself. That's because of the rank. So 524 for me is like as good as 1, because I could actually do everything. I could actually do everything out of the course that I expected or I anticipated. So in that regard, this is a very important exam. So give it your everything, go hard, and you have everything that you need you right now. So the only thing is that you have to keep quiet and study, rather than going around talking this, that, etc. Just have to focus on your work. On the whole, it's people who just sit quietly and do their job who finally turn out to be very successful. So just sit in your home, focus, relax, and keep pushing hard towards your goal, because it's essentially not like a goal, but to make a difference with respect to your performance, and to make yourself proud and make yourself more confident as you push ahead. So you have enough and more data with you now. You have everything that you really want. Edition 6.5 is there, edition 8 is there. You can choose whichever one you want, depending upon the time. If you are a little short of time, you can go for edition 8. If you're having enough and more time, you can go for edition 6.5. Then you are having 32 hours of revision, which is a sequential revision, which is going chapter wise. You have your question bank to solve your questions. You have GTs going on one side. Then additional 8 hours of integrated problem solving kind of stuff that we have added. So there is enough and more. Just have to remain calm, just have to remain focused, and just have to get on with your job. There is nothing else that is preventing you from reaching where you want, at least in our country. And for others who are planning to shift abroad or going to move abroad, my only request is, if you have a PG with you, then that will make you much more better, much more confident, and much more recognized when you move abroad, rather than with a plain MBBS. When you move abroad, then the going is going to be tough, but how you take it is purely your own thing. So finally, best wishes, and 6 months for the next INI. Not really sure when the next NEET is going to be, but 6 months for the next INI, everything to play for. And you know that, okay, these are the zones. Once you watch these 9 recall videos, you will know the zones. Focus on the zones and try and get into INI, whatever be the subject, because in one way, a Central Institute can change your career. It can really make a big difference with respect to your career. So wishing the very best. Thank you.